respiratory pharmacology, histamine blockers. All right, once again, for all my pharmacology sections, they're going to be short and sweet and relatively high yield stuff. I'm not going to go into the lower yield stuff, but I 1000% recommend watching the videos on Sketchy and then putting them into your Anki so you can get a full understanding of these medications and you don't have to waste time. Okay, first, histamine blockers, also known as antihistamine, right? H1 blockers. They reversibly inhibit H1 histamine receptors. Okay, there's H2 receptors that we're going to learn about later on, but H1 blockers are specifically for our lungs. So that's what we're learning in this respiratory section. There's two generations. There's first generation and second generation. First generation crosses the CNS, and it can lead to potential adverse effects of like sedation, as well as anti-muscarinic and anti-alpha adrenergic effects. So you can get hypotension, you can get anti-serotonergic effects, which leads to an increase in appetite and weight gain. And that sedation can lead, because it can cross the blood-brain barrier, it can lead to sedation. So like elderly patients can fall and stuff like that. And that's the key difference between first generation and second generation. Second generation, they don't have those anti-muscarinic, anti-alpha adrenergic, or anti-serotonergic effects, and they do not enter the CNS. So you don't see the sedation for second generation histamine blockers. Now, the names of the first generation is diphenhydramine is the main one you have to know. It aids in sleep aid, right? Because it can cross the CNS. But also allergy, motion sickness, and vomiting in pregnancy. You have chlorpheniramine, okay? And then that's pretty much the two higher yield ones. The second generation one, you have to know loratadine, fexofenadine, and desloratadine, okay? As well as cetrizine, okay? Cetrizine. These are all used only for allergy. You can't use them for sleep aid because, once again, they don't cross the CNS. That's the main takeaway, okay? Next is dextromethorphan. For dextromethorphan, it's an antitussive, okay? So it's against coughing, essentially. So it blocks coughing. And all it does is it antagonizes the NMDA glutamate receptor. We're going to talk about it later on in the opioids, so like in neuro or psych. And it acts on the sigma receptors to suppress the medullary cough center. That's all you have to know about it. It really is low yield, okay? Moving on to pulmonary hypertension drugs, we already talked about it, right? We know that we're going to use bosentan, which is an endothelial receptor antagonist. It competitively antagonizes the endothelin-1 receptor, and it leads to an overall decrease in pulmonary vascular resistance. Okay, bosentan is our primary treatment. You also have PDE5 inhibitors. PDE5 inhibitors are going to increase CGMP, and they prolong vasodilatory effects of nitric oxide, right? And this is going to be also known, this is sildenafil, okay? Also known as the blue pill. Right? And so patients are going to be using this for erectile dysfunction. It's contraindicated, though, severely with patients that are going to be given nitroglycerin for maybe patients that have, angina symptoms, okay? But PDE5 inhibitors, they just increase CGMP and they prolong vasodilatory effects of NO used for erectile dysfunction. One of the drug names is sildenafil, and that's all you have to really know. And that contraindication is very important as well. Lastly is prostacyclin analogs. Prostacyclin analogs, they inhibit platelet aggregation. It's a very key effect. And they directly vasodilate the pulmonary and systemic arterial vascular beds, okay? Lastly are our asthma drugs, okay? Our asthma drugs are very high yield, but overall, what I will say about all of the respiratory pharmacology, it's not as in yield as you need it to be. But within respiratory pharmacology, I'd say asthma drugs are the highest yield. First and foremost, we have inhaled beta-2 agonists. So beta-2 agonists are going to be dilating our respiratory, or essentially our whole entire respiratory tree, right? So these are albuterol, salmeterol, and formoterol. Okay, they end in ROL, whereas beta blockers end in LOL, right? Beta-1 blockers, right? They end in LOL. These are inhaled beta-2 agonists, okay, so opposite of beta blockers, and they end in ROL. Two differences. Albuterol is a quick-acting beta-2 agonist. Okay, and salmeterol and formoterol are going to be longer acting beta-2 agonists. And what they're going to do is they're going to relax bronchial smooth muscle. Okay, very, very easy. And how do they do all this? They increase CAMP. We knew that because for our beta receptors, that's how they act. They act by increasing CAMP. Cool. Moving on is inhaled glucocorticoids. Inhaled glucocorticoids is very, very effective. These are fluticasone and budesonide. Okay. I'm really bad with the names, but once again, look at those names yourselves. But what they do is they're going to block inflammation because these are inhaled glucocorticoids. So they inhibit the synthesis of all cytokines and they inactivate NF-kappa B, which is very useful for our inflammation. So if we inactivate NF-kappa B, we're going to block inflammation. All right. Now, they use this in chronic asthma, and you're going to use a spacer or rinse mouth after use to prevent oral flush. And that's something that they love to ask about. So a patient that's on inhaled glucocorticoids, they have an increased risk for oral thrush. And the way that you can, easy question to get right is you just swish and spit, okay? So you just like rinse out your mouth after you inhale glucocorticoids. Next is muscarinic antagonists. These are tiotropium and ipratropium. You've already learned about them earlier on in your studies for Neomed. And essentially they competitively block muscarinic receptors and they lead to bronchodilation. Okay, they're used for COPD patients, and what you have to know is that tiotropium is longer acting. Next are anti-leukotrienes. These are montelukast and zafralukast. They end in leucast, okay, and they act via GPCRs, okay, and they block our leukotriene receptor cis-LT1, okay, and they're very good for aspirin-induced asthma. That's a question that they're going to ask you, because once again, if we take aspirin and it leads to asthma, that means that we have a buildup of, right, we're blocking COX, so we're going to go back to arachidonic acid, and arachidonic acid has nowhere to go because it can't go down the COX pathway because you took aspirin. So it's going to go down the leukotriene pathway, and it's going to lead to all the symptoms that we're going to see in asthma. So a way to solve that problem is blocking the leukotriene pathway and by giving them montelukast and zafralukast. Xylutin is also an anti-leukotriene, but it's a 5-lipoxygenase inhibitor, so 5 LOX, okay? It decreases the conversion of arachidonic acid to leukotrienes, and that's the step in between. So arachidonic acid needs 5-lipoxygenase to get into leukotrienes, but it has an increased risk for hepatotoxicity, so be careful when giving xylutin. Next is omalizumab. Omalizumab is essentially going to bind, okay, to our serum IgE and block it from actually doing its job. That's all it is, right? So IgE levels are going to be increased in levels of patients that have asthma, right? Because this is our asthma reaction to our antibody of IgE. So if we just essentially bind IgE, we won't let it do its action, and that's omalizumab. It's going to bind the Fc region of the IgE, okay? Next is theophylline. Theophylline is going to cause bronchodilation by inhibiting phosphodiesterase, so it's going to lead to an overall increase in CAMP, okay? But it's metabolized by cytochrome P450, so you have to be worried. It blocks the actions of adenosine as well, okay? So theophylline, they don't really use it that much because it's very, very toxic, and you're going to see patients that are nausea, vomiting, seizures. They're going to be trembling a lot, so keep that in the back of your mind as adverse effects. Cromolyn is another thing. It prevents mast cell degranulation. So it does not allow for mast cells to fully release histamine overall, okay? So in response to IgE, IgE is going to bind to our mast cells, and it's going to lead to degranulation. Cromolyn is going to block that degranulation, okay? And omalizumab is going to block the IgE from even binding to the mast cells, all right? Lastly, our corticosteroids are going to increase beta-2 receptors on bronchial smooth muscle, and they can cause apoptosis of tissue eosinophils. That's something that's lower yield, but I just had to add it in there. That's all for our asthma drugs, as well as all other drugs for the pharmacology of the respiratory system, and we'll be moving on to our endocrine reproductive in the next chapters.